Hello everyone and welcome to Lehigh Valley Health Network Education Center. I'm Dr. Tom Meade and I am here with my orthopedic surgical colleague, Dr. Eric Lebby. We are here to discuss something Lehigh Valley Health Network is very good at and has been doing for 15 years, and that's orthopedic specialty hospitals. So we commend people that had some foresight a while ago to realize that we don't need all the assets at a tertiary care center to do elective orthopedic surgery. The majority of orthopedic surgery in this country is done as an outpatient. In general, these are not sick people. These are healthy people that have joint or musculoskeletal injuries. So the best place, the safest place, the best outcomes are in orthopedic specialty hospitals. I've had the privilege of being involved from the beginning in designing some of these facilities. And some of them are beautiful and they're huge and they're wonderful. But you know what I've learned over the years? That it's not the bricks and mortar that's important. You know what's important is the people. It's the people. And you know what I tell patients that come in? And they say, my family, went to a different city or they went to a different institution. And I said, it doesn't matter what city you go to, what institution you go to. It's who you get there, what people take care of you. And you know what? Here in the Lehigh Valley at our specialty hospitals, when we're compared against over 1,600 orthopedic centers in the country, we came out in the top 1.5%, ahead of some of these nationally ranked facilities in our closest big town of Philadelphia. And you know what? It's because of you. We were just talking, Eric and I and the crowd here, if you're the pilot of an airline and he has no crew, you can't take off. You are nothing without the crew. We are nothing without the folks here. So with that introduction, we have now, Lehigh Valley has, at least that I know of, 6 micro hospitals. The majority of the surgery is orthopedic surgery, and there's 2 more under construction. So I thank you for coming. This just represents a few of the staff at 2 of the facilities that I work at, Dr. Lebby works at. And so, Eric, why don't you introduce our 2 facilities?
Yeah. Thanks, Tom. I think you brought up a lot of great points in your introduction, but I think it's very important to understand that Lehigh Valley Health Network is really leading exactly what you were talking about, because the future is not inpatient-based medicine. It's really outpatient-based medicine. So our CEO, Dr. Nestor, is really big on the value-based medicine. And Lehigh Valley Health Network is doing that value-based medicine care where we value the patient, we care for the patient, and try to keep the patient out of the hospital. And because of places like Tillman Orthopedic Specialty Hospital and Allentown Specialty Hospital, we are keeping patients out of the hospital because we're performing the orthopedic surgery that they need, but we're really essentially keeping them out of the hospital. And it's exactly like you said, it's not the bricks, it's not the mortar, it's the people inside. We could people can build buildings, but if you don't put people inside of it like we do, then those buildings are exactly what they are, buildings. So it's like you said, we've been doing this for, combined both hospitals over 15 years. And, we're not new at this. And there's a reason why we're, second in the state, number 27 out of 1,660 some hospitals in the nation. And he said, Philadelphia, we're ahead of Jefferson. That says something. We're ahead of Rothman Institute. 1.5% in the nation, that's what we are, and it's because of you guys. I am 100% in agreement with Tom that we are at the bottom. Tom and I look at ourselves as the bottom, and you guys make us what we are. My patients don't say, oh, Dr. Lebby, you are the greatest. My patients talk about Colleen, my PA. They talk about the nurses in the OR. They talk about their experience at Tillman, and that's why they come back. I mean, I've worked at places, and it's it's not fun. I have fun every day with these people. These people are my friends. I've known Luann for 20 years, since I've been here. She was a scrub nurse with me when I first came here. And want to talk about going up the leadership chain, there's nobody that I look to more for leadership as a nurse than Luann. Right? My PA Colleen and I work hand in hand every day. Steph, Beck, my rep is in the audience, Lou Zavacki, right? I mean, he works with Depew, and I couldn't do the work I do without him. He organizes everything along with the nurses, so everything's at my fingertips. I'd be kidding myself if I thought I could do this without any one of these people. Deb is up there in the audience too. I'm sorry, and I don't work with people at Allentown, so Tom's going to bring you guys into it. But Deb, I mean, talk about controlling the OR. She's basically she's our head technical partner, and things wouldn't happen without her. And from top to bottom, whether it's the environmental services, whether it's the nurse, whether it's the anesthetist, whether it's the anesthesiologist, whether it's the tech, we can't do what we do without these people.
So, yeah, before we talk more, because you and I could talk an awful lot, it just reminded me that we should put up a disclaimer that says, whatever we talk about is our opinion. This is not the opinion of Lehigh Valley Health Network, Lehigh Valley Orthopedic Institute. So just for that, we hope that they appreciate what we say and it's very accurate. And we're not here to give medical advice. I don't even think we're going to talk much about medical advice, but if it does sneak out, don't listen to it. You have to listen to your own physician. But to Eric's point, I like being honest, and there's a lot of people out there in the public that, we have a lot of physicians in our group, and they think that we all get together at night and we go to the same dorm and we talk to each other and then we get up and go to work in the morning. We are closer with our team than we are with our colleagues. I know some colleagues very closely, like Eric, we work in the same department, but we are closer to our team. And that's important because it's the teams really that make success. And we know that we have to treat that team well. There's two platforms of treating patients. The institution that we're not in that much of a control with, but they have to treat you fairly. They have to reimburse you fairly. But it's more important the team that you work with, because workers can be subtle. They don't have to gravitate to Dr. Lebby's team or my team. So we understand that. And you know what? We do a lot of work. And I think the folks that want to work hard and do a great job are attracted to the teams that are really, really committed to outcomes. So I appreciate you coming here. And
one more thing to add to that, Tom.
Yeah.
In their defense,
Yes.
they work with a lot of personalities, and some of them aren't the greatest personalities because we're surgeons. And for them to be able to keep us together is just it more exemplifies what a family does, right? And when you're talking about families, I don't know about you guys, I probably spend more time with the people at Tillman than I do at home almost. I mean, you have to like and have to want to be with the people and have to like what you're doing to be with the people. And that's the biggest thing that I think that these people in the audience show our patients, is that they care. The patients aren't a number, it's a family. The amount of thank you notes that I see on the walls, the happy patients, the candies, the catered lunches that people send after their surgery, it speaks mounds, and it's not because of you, it's not because of me. We might think so, but it's not. It's really because of them, and that's what makes the two hospitals and our six future micro hospitals, because we're going to build them the same way.
Well, you know what you just said is you said family. And these are not chess pieces that are interchangeable out here in the audience. You know what? They're real people. They have real families. They have problems like we all do. And I think that's what happens in families. We celebrate good things and we support when bad things happen. And we all know when bad things happen because that's what we talk about in the OR. And we appreciate it so much. Really, you can get emotional, the amount of people that help us when something bad in our family happens, or something and we know it. And so that's the value of families, and that's what we appreciate.
100%.
So our agenda, and is what we wanted to, and we may not get there, but we just wanted to go over the different groups in our OR, appreciate that. We talked about the micro hospitals. Some people don't even know what a micro hospital is, but Eric is smarter than me, so he's gonna explain that after the break. And then we're gonna, talk about some personal team stories, and I'm gonna pick on people up there, because I see some great stories up there, and even some patient. We had some patients come in, and we're gonna ask them their experience, because as Eric said, what happens is, and Patty, I remember this last week, a patient is sitting there in the chair going, oh my God, these people are great. And we kind of fool around and we say, is it 4-star or 5-star? And they all give you 6 stars. So, it's kind of funny. But anyway, so let's come back after the break. We'll have Eric describe what a micro hospital is. And then I want to drill down onto the different teams that we have, explain that, and then ask some personal stories. So stay with us. So welcome back. We're talking about micro hospitals, and some people think it's maybe those little houses they had when they were kids or something. It's a little hospital, but really we all, we grew up in these massive, hospitals. So I don't know, Eric, in 30 seconds, how would you describe a micro hospital?
So what I look at, it's like I said, it's the opposite of a macro hospital. But no, I'm kidding. What I really think the best difference between a micro hospital and thinking about a very large hospital is it's just all in one spot. You're right there. You don't have to worry about all the corridors, all the turns, all the different floors, the different departments. It's really a specialty hospital. That's how I look at a micro hospital. It caters to specific specialties. And I look at our micro hospitals, the greatest orthopedic hospital on, I would say, the East Coast. We're nationally ranked. We're the top, so I think that's what sets it aside from, you don't hear trauma alert, level 1 trauma alert, you don't hear code floor 2, or, it's kind of like a little tiny boutique that offers everything, as opposed to, Neiman Marcus, the whole big store. That's kind of the way I look at it, and that's really what makes it special. And it's the little departments within our micro hospital that make it special.
I agree. You go to Midas, they're good at mufflers. You go to our orthopedic specialty hospitals, that's all we do. It's interesting, if somebody comes into our operating room and they watch us operate, most of them come in because a rep brought them in and said, you have to watch Dr. Lebby do a hip procedure, total knee. They leave going, I really don't want what Dr. Lebby does. I want his team. How do you get a team to do that? And we see that all the time because we don't repeat steps. We are very efficient. Everybody in our room knows the next step. If we ask for something, it takes too long. It takes too long. It's there.
The key word is it's reproducible, right? So whether I have Steph, whether I have Becky, whether I have another nurse in my room who's scrubbing, they know what I do, and they know the system, they know the steps, they know the case front to back. And I'm happy to say this, if God forbid something happened to me in the middle of a case, Tom, and I hit the deck, I know that Colleen or Dana and my scrub tech, Jesus, and the scrub nurse or the scrub tech, they would finish the case. They would finish the case. They could finish the case without me, because I've done it enough times with them, and they know my steps, where I feel that comfortable in a room where I could do that. I don't want to work at a place where I don't know the scrub nurse, I don't know the tech, and it's a new person every time. And that's the scary thing. You can be a very, very good surgeon. If you're thrown into the wrong situation, that's not going to be a good outcome. We are just one piece of the puzzle in a good outcome. There are so many more pieces to the puzzle in that good outcome.
Now, to your point, and we'll go over the different, teams in the OR, but we have, to go back to the pilot analogy, you have a pilot. We have many co-pilots. We have the anesthesia co-pilot that's keeping the vital signs stable. But to your point, we have PAs, we have ortho techs, we have scrub techs, we have first assistants. And they know, and they are helping us. I always say it's not my hands and my eyes. There's 8 eyes and 8 hands around the table. And you know what? Every case, somebody will pick up something. It could be, Ashley, it could be Tyler, it could be Mike or Tom, and they'll say, what about this? What about that? You'll grab an instrument and, Ashley will say, that's not the next step, and the next step comes. So the check and balances is not one or two, it's 8 eyes and 8 hands, which is pretty cool.
Yeah, absolutely.
So let me sort of go over the steps. I didn't pick on anybody, and you're pretty happy so far. But and by going over the teams, these are just the teams that get the plane to take off.
There's so much more that's involved. There's so many more. You couldn't even put the people on a list from when you walk in the door to when you walk into your car. There's so much that goes on. And the thing that makes this so tricky is one little function of that whole process goes wrong, the whole thing topples down. Yes. If someone is not nice to you at the front door, when you leave, you're going to say you didn't have a good experience. If someone at the back door isn't nice to you, you're going to say you didn't have a good experience. And that's what you don't see at Tillman. You don't see, or at Allentown, you don't see those.
It does. It goes in the toilet. Right. It goes in the toilet if one of those things goes wrong.
There it is.
And then Ashley gives us a poop icon. It's terrible. But to Eric's point, this is the OR, and so preoperative, and I may be missing somebody, but from what I see, you have nurses and anesthesia out front. The anesthesiologist, and a lot of people don't realize that he is so important to review the case, do everything up front, and a lot of times, depending on the hospital, he can do the block up front or he could do the spinal. But then he hands off. He hands off in the OR, and the nurse anesthetist is as equal or more important in the OR because they're there for every minute, and you have to appreciate that.
One thing, though, because
yes.
I think it's important, somebody you forgot to mention is environmental services and the technicians, because without I see them, they're there before I am. And that room is spotless for that patient, because if that patient goes into the room and it's not clean, that's a bad experience for them the whole time. Infection. So we I know Cheryl, Maria, I know people by name, and I say hello to them every morning because it's so important. And Deb, who makes the OR run, I think they're as important pre-op as the RNs and anesthesia, to be honest with you.
And then again, just to continue in the OR, we have anesthesia PAs, nurses, scrub techs, as you said, ancillaries, and then, as you said, we put ourselves at the bottom. If all those ducks aren't in order, then the case goes in the toilet, just like the slide shows. And then PACU, we go back, and the anesthesiologist takes the handoff from the CRNA, because they go into the next case. And then if there's a problem in the recovery room, that's where they're there, and the nurses. And you see these 3 circles? There's 3 circles that aren't there in front and 3 circles on the back, because to get the patients there, we don't want to change our office staff, the labs, the pre-op clearances, the post-op physical therapy, all the things that are necessary. But it gives people the idea of the complexity and how the teams need to be integrated to have a successful outcome. So that being said, I think we might have time for just a few aspects of this. So I think I'm going to call on Stacy. Now, Stacy's what we call a utility player. Because Stacy's a nurse. Stacy, grab the microphone there. So really, I've known Stacy for a long time. You work in pre-op, and you work in post-op. So you can do a lot of things. Your experience in working, and it's in close proximity. Our pre-op and post-op can fit in this room as opposed to a tertiary care center. So give me your feel from a nursing standpoint of where I misled people in this dissertation or what you could confirm.
I don't think you have misled anybody. It's absolutely true. We all have to work together, the anesthesiologist, the nurses, and pre-op, to get your spinals done in the pre-op unit. Make sure medications were stopped or held or given as you require, because I know you have a whole protocol. So we work together right from the very, very beginning to make sure that everything's safe to go.
And for continuity of care, I see it at Tillman and I see it at our place. It's sort of interesting. Sometimes the same nurse sees that patient from when they come and and when they leave, you know?
Yep. There are times I've been fortunate enough to have the same patient both in pre-op and post-op.
Yes.
So that works out very nicely because we do know the whole, I don't know, cycle that they go through.
And just to make life easy, because we don't want to slide the microphone too far, why don't you give it to Patty? And Patty, give us your experience of being in the PACU, which is where you spend most of your time. But you double, so in the PACU, we send a lot of people home. And what we found out is that you double as physical therapists because you know what we do. I've been in other hospitals where they send them off the floor, up the elevator to a third floor, but we do the same thing. And from your standpoint, I watch you guys. You are so good at explaining everything from the therapy, the exercises, how not to fall, and all the things. But, you know, you do so much more than nursing. Do you agree?
I agree, yeah. And I think it's really important. A big part of the success of all this is that the patients are educated ahead of time. You know, in the office and then with your pamphlets, your booklet that's coming out. And then again, in pre-op, you know, they do a lot of education there too. And then of course in the OR, you know, the patients are asleep. But then when they come back out, yeah, we go over everything thoroughly, ask them what they've read, demonstrate to them how to get up, how to stand, how to sit. And then to top it all off, you come over and you repeat everything. And so they get that constant reinforcement, you know, so that they know exactly what to do when they go home. So they do have a successful outcome.
And so we used to give when Eric and I started, you're in the hospital forever, you're on morphine pumps, we didn't know pain management. How do you see the narcotic requirements of the orthopedic patient in the recovery room now versus historically what we used to do?
I think it's awesome. A lot of people tell me, a lot of the patients say they never have had to even take narcotics after their surgeries, because the way you have that protocol set up, they have so many meds that are able to take care of their pain and their inflammation and such like that, so that by the time the local anesthetic wears off, they don't need as many narcotics, if at all. So that decreases their chances of falling, which then again, you know, goes toward a successful outcome. So I think it's definitely gotten better. You know, the fact that they don't have pain for at least, 48 hours, that's a miracle. And then they can get, they can start in on their exercises and then, go towards recovery, what they really need to get done. So,
what a big pendulum swing I saw was historically, they came out and they asked patients, what's your pain level? Meaning you have pain, give it to me. And as soon as they have pain, they say, well, let me give you something to preempt the pain. And that has gone away. And you guys are very good at that. I trust you implicitly. I trust you to say, this patient can't get up yet. They can't stand. They're going to fall. And I go, then whatever you do, Patty, Stacy, you tell me when they're ready. Because if they fall, it's a disaster. It's a disaster. I tell patients, don't fall when you go home. I give them a lot of instructions. I say, when I see you back a week later, if you don't do one thing I say, but you didn't fall, I'd say that's okay. It's that bad if you fall. You know what I mean?
And that's another thing that we do very well at Tillman too is, we have nurses downstairs that do the same thing, and we also have nurses upstairs that do the same thing. And we get them in therapy as quick as we can, but we listen to the nurses, we listen to the therapist and says, this patient can go, this patient needs some more care. And that's what, I think sets us above the rest.
I agree. So, we didn't do a good job of incorporating many of the staff up here or the patients. So we're going to roll into a second program, so stay with us. We weren't sure about this, but I think it's exciting enough. People want to hear about this, so stay with us for part 2 of the show.